Yes. Good afternoon, one and all. Welcome. Could you please grab your lunch and take your seats? And once you've done that, we're going to begin the session. Come right in, please. All right, let me make a start. Good. So let's make a start. So my name is Anselm Hennis. I'm Director of Non-Communicable Disease and Mental Health. So honorable ministers, distinguished members of delegations, Dr. Barbosa, distinguished members of the panel, ladies and gentlemen, colleagues, welcome to this briefing session on cervical cancer elimination, advancing the call to action in the Americas. Now, as you may know, cervical cancer is the fourth most common cancer in women globally, affecting about 78,000 women. And it disproportionately affects women in low and middle-income countries. And this is no exception in the region of the Americas. Cervical cancer is a disease underpinned by health disparities, which we see very clearly in the Americas. So as such, mortality rates are 3 times higher in Latin America and the Caribbean than in North America, which underscores inequalities in income, gender, and access to health services. However, the reality is that cervical cancer is eminently preventable, and we hear a lot more about that during the session. In 2018, PAHO established a renewed regional plan of action for cervical cancer prevention and control, and then in 2020, the World Health Assembly adopted a strategy for the elimination of cervical cancer as a public health problem, with the goal of reducing the incidence of cervical cancer to below 4 incident cases per 100,000 women in all countries. So this session has the objective of showing regional progress on the global targets for HPV vaccination coverage, HPV testing and treatment, and promotional strategies to increase coverage towards cervical cancer elimination. Secondly, to stimulate countries to implement comprehensive cervical cancer programs by showcasing selected country best practices, results, and innovative approaches towards cervical cancer elimination. And thirdly, to engage member states on the outcomes and commitments emerging from the Global Cervical Cancer Elimination Forum. It therefore gives me great pleasure to invite Dr. Jarvis Barbosa to give the welcome remarks.
Thank you, Anselm. Good afternoon. Buenas tardes, distinguidos representantes.
Good afternoon, distinguished representatives of member states. I'm pleased to welcome you to this session on cervical cancer elimination in the Americas. Allow me to especially greet Reina Roa. She is from the Ministry of Health of Panama, and Dr. Roberto Bonilla, who is head of the International Cooperation Agency in El Salvador, and Dr. Maria Teresa Barang Machinchuki, I don't know if I got that right, the Minister of Public Health in Paraguay, and also the president of our 61st Directing Council meeting. So they are going to be on the panel for this special session. We know that cervical cancer is one of the major causes of death of women in Latin America and the Caribbean, although there is a vaccine against human papilloma virus and treatment to prevent this cancer. Now, here we're going to talk about the regional progress towards future elimination of cervical cancer by accomplishing the worldwide objective of 90% coverage of vaccination, 70% screening, and 90% of treatment of VPH. Since 2018, when the Action Plan for Prevention and Control of Cervical Cancer was approved in the Directing Council, the Organization of Pan-American the Pan American Health Organization has been working with member states to strengthen their comprehensive programs to control cervical cancer with a view to reducing the burden of this disease in the Americas. And we are very proud in the region to have many strategies to expand vaccination against HPV. And by using screening, and we are the leading region in the world that can eliminate cervical cancer. We can and we should. It's important to point out that elimination of cervical cancer could save the life of more than 40,000 women a year in the Americas. And we know that these women are generally women from the most vulnerable populations in the region. So by eliminating cervical cancer, we are also promoting equity within the region by lowering mortality amongst these women that would leave behind families that are often poor, that live in the poorer sectors of large cities, also mothers, wives that live in rural areas, often people from indigenous populations, and they leave behind orphans because they die from cervical cancer. So to have a single dose vaccination against HPV, especially in schools, as well as doing HPV testing, including new testing with the possibility of self-collecting and with tests that are much more accurate than the traditional pap smear. And this is an effort. We are trying to provide these new tests at affordable prices for our member states by using the strategic PAHO fund. So these are some of the key measures to deal with this disease and to make certain that the Americas, once again, will be leading this effort to eliminate the disease. We congratulate the 24 countries and territories that have changed their vaccination regime using a single dose, and we are more than available to share the evidence that exists. That is what is the recommendation of the Strategic Advisory Group, the SAGE within PAHO, and we have a technical group that provides advice on vaccination. This will enable the countries to use vaccine for more people, to vaccinate children and to vaccinate other age groups with the vaccines that would be saved, quote, quote, by using the single-dose regime. Also, I wanted to congratulate the countries that have already introduced HPV testing to detect cervical cancer. We're working with them so that this can be provided in more countries in the region. Now I will go into English.
The elimination target is for 90% HPV vaccine coverage, 70% screening coverage, and 90% treatment coverage is reinforced by the PAHO Disease Elimination Initiative, which we spoke about in Monday's briefing session. In today's session, we aim to inspire and motivate our countries and partners, and I want to thank many parties that are here today that participated in the event that we had during the United Nations General Assembly and the dinner that we had also during the UNGA in order to bring more partners for this very, I think that challenging but achievable task that is to eliminate cervical cancer in the Americas. So I want to thank all of you because I think that this is a very important challenge for our region. Through PAHO's regional revolving funds, HPV vaccines, HPV tests, and ablative treatment devices are available to our member states at one unique price, regardless of the purchase size. I also want to encourage the 3 countries that are still missing to introduce HPV. We are already supporting these countries. I particularly talked last week with the new Gavi CEO about how we can provide support so we can have maybe this year or maybe next year in the first semester, if it's possible, all the 51 countries and territories of the Americas with the HPV vaccine being implemented. I reaffirm PAHO's commitment to work closely with all of you, bringing together partners, technical cooperation, and resources to accelerate the implementation of the strategy that will contribute to our region being the first in the world to reach the 90/70/90 targets by 2030 and save women's lives from cervical cancer. Thank you for your attention and dedication to this very important goal. Thank you.
Thank you so much, Dr. Barbosa. Now I'll invite the Assistant Director, Dr. Rhonda Seeley-Thomas, to present an overview on the elimination of cervical cancer in the Americas. Welcome.
Thank you, Dr. Hennis. Good afternoon, Dr. Barbosa, ministers, ambassadors, delegates, panelists. Good afternoon. It's always a challenge to speak after Dr. Barbosa, and especially since we're short of time this afternoon. So I'm going to be very brief. As Dr. Barbosa would have said, we are working towards the WHO's 90/70/90 targets, where we want to reduce the incidence of cervical cancer to 4 new cases per 100,000 women. And these targets are to establish 90% HPV vaccination coverage in girls by the age of 15 years, 70% screening coverage, and 90% treatment coverage. These, as Dr. Barbosa would have alluded to, are commonly referred to as the 90/70/90 targets. And while ambitious, the region of the Americas is well positioned to eliminate cervical cancer given its history with polio and smallpox elimination and its well-developed immunization programs. If we look at the cervical cancer incidence in the Americas, and no, I don't expect you to read this slide, it actually gives us a snapshot of the incidence in the Americas, showing that there's a wide variation in the incidence rate across the Americas. As depicted in the graph, countries at the bottom of the incidence ranking are closer to the elimination goal, which makes elimination possible in a shorter time compared to countries shown at the top, and in particular those with an incidence over 30 per 100,000 women. So at the bottom of the slide, we have an incidence rate of about 6.3 per 100,000 women, and at the top, we have countries with an incident rate as high as 38 per 100,000 women. We urgently need to accelerate our efforts to ensure we meet the goal of the 90/70/90 targets so that countries can be on their way to eliminate cervical cancer. Achieving this will necessitate prevention through vaccination, detection through good screening, and treatment. If we look a little bit closer at HPV vaccination in the Americas, as Dr. Barbosa would have alluded to in his presentation and his remarks, 48 out of 51 countries in the Americas have introduced HPV vaccines. 24 countries and territories have switched to one-dose schedule, and there's 77% coverage for the first dose in girls and 42% coverage in boys by the age of 15 years. 74% of countries and territories have the school-based approach, and we recognize that school provides a very good opportunity for us to vaccinate both girls and boys, and we really urge our countries in the Americas to do this. In terms of cervical cancer elimination, of course, vaccination is not enough. Elimination can be achieved faster if vaccination is coupled with screening, using high-performance tests such as HPV testing, and ensuring women are detected with precancer and are treated and are not lost to follow-up care. While screening programs exist in all countries, screening coverage varies widely from low to 10% to a high of 80% in the region of the Americas. Most countries continue using cytology testing and have not yet transitioned to HPV testing, which is a more modern and more effective test to detect precancerous lesions. 4 countries have achieved national HPV testing, and they include Antigua and Barbuda, Argentina, El Salvador, and Mexico. Access to treatment, however, continues to be a challenge in all countries. We have the tools to prevent, treat, and eventually eliminate cervical cancer as a public health problem, and we urge countries to consider introducing HPV tests in their screening program and to increase access to treatment services. Ladies and gentlemen, the Pan American Health Organization has the means to support you in this effort and can provide technical support to our member states to strengthen and increase HPV vaccination coverage, introduce HPV testing, and expand access to treatment through the utilization of the PAHO Revolving Fund, as Dr. Barbosa would have alluded to, and also affordable HPV vaccines. HPV tests and pre-cancer treatment devices are available. The time to act is now. We have the history in the region of the Americas for disease elimination. We have the tools through the PAHO Revolving Fund. We have a disease, cancer, that we can detect, we can prevent, and we can treat. Ladies and gentlemen, the time to act is now. No woman in the region of the Americas should die from cervical cancer because we have the tools, we have the experience. The time is now. Thank you.
Yes, thank you, Dr. Celie Thomas. The time is indeed now. We're going to present a video on cervical cancer elimination.
In the world, every 2 minutes, a woman dies of cervical cancer, a disease preventable through vaccination and screening and treatable. Every death is a tragedy that we must prevent. In the Americas, cervical cancer is a common disease that kills nearly 38,000 women each year. The lack of equity in access to prevention and care is reflected in the difference in mortality rates. In Latin America and the Caribbean, there are 4 times more deaths due to cervical cancer than in the United States and Canada. That is why the Pan American Health Organization is implementing the World Health Organization's strategy to accelerate the elimination of cervical cancer with specific goals for the year 2030 that is based on 3 main pillars: vaccination, screening, and treatment. By 2030, 90% of girls must be vaccinated with the human papillomavirus or HPV vaccine by the age of 15. 70% of women should be screened using a high-performance test such as the HPV test by age 35 and again by age 45. 90% of women with precancerous lesions and invasive cancer should receive appropriate treatment. The Pan American Health Organization, PAHO, provides technical cooperation to the governments of the region to achieve these goals. Through the Revolving Fund and Strategic Fund, PAHO makes HPV vaccines and HPV testing available at a lower cost. It is time to join efforts to adopt and promote an ambitious, coordinated, and inclusive strategy to accelerate the elimination of cervical cancer as a public health problem in the Americas.
Thank you so much. And now we move on to the panel discussion. I will present Dr. Silvana Luciani, Unit Chief of Non-Communicable Diseases and Violence Injury Prevention in NMH, and also recognize public health expert in cervical cancer in the region.
Thank you very much, Dr. Hannes, and a great thank you to Dr. Barbosa and Dr. Celie Thomas, who needed to run to another meeting. But it's a real honor and privilege for me to be moderating this important session on cervical cancer. I am part of a wonderful team working here at PAHO to help implement these very innovative strategies that we have: HPV vaccination, HPV testing, treatment of precancerous and invasive cancer lesions. We're working across programs in cancer, immunization, regional revolving funds, women's health, and of course the Elimination Initiative. And we have tremendous support from PAHO leadership, which makes our work and our support to you, our member states, much easier. And we're all really, really excited, not only about the potential to eliminate cervical cancer, to be the first world region to eliminate a cancer. But we're really excited about the feasibility of doing so because we know many of our countries are already on the path towards that ultimate goal of reaching that incidence of 4 per 100,000. But as Dr. Seeley Thomas has presented, we know there's a wide range in the region of incidence rates across countries. So the time to reach elimination will certainly vary by countries. But in the short term, between now and 2030, that is in the next 6 years, we're really focusing our efforts on reaching those high coverage targets, 90% for HPV vaccination in girls before 15, at least 70% screening coverage using HPV testing in girls primarily 30 to 49 years of age, and at least 90% coverage for treatment services for women with precancerous lesions as well as cancer treatment. And we know this is ambitious, but we know it can be achieved because these are fundamental public health strategies that we're talking about. Immunization programs, all countries have them. HPV vaccines are part of that. Public health primary care services that screen women and offer precancer treatment services and primary care exist in many countries. We just need to strengthen the services, the immunization programs, and adopt some of the innovations like the one-dose strategy, adopt the HPV testing, use self-sampling as an innovative strategy. So we're really excited to have this panel to discuss some of the experiences. And I'll switch to Spanish now, porque estamos muy...
Because we're very excited to have public health leaders from our region here, Dr. Reina Roa from Panama, the General Director of the Ministry of Health, and then from El Salvador, Dr. Roberto Bonilla, Chief of the International Office of the Ministry of Health, and of course, the Public Health Minister of Paraguay, Maria Teresa Baran, who will be sharing with us all of their lessons, good practices and experiences with the implementation of these comprehensive cervical cancer programs to spur all countries of Latin America and the Caribbean to adopt these strategies. Welcome to the panel, and we're very happy to have you here and to hear your experiences. I would like to start first with the HPV vaccines, one of the few cancers for which there is a vaccine that can prevent cancer. Since 2006, when the vaccine was released on the market, it's been 18 years of experience. And Panama was one of the pioneer countries introducing the vaccine against HPV. So if you could tell us a little bit about the long experience that you have had and what you're doing by way of experimentation in your country and what you've undergone. Thank you very much for the invitation. Yes, we started in 2010 in girls under 10, vaccinating or of 10 years of age, and our experience was quite good. This is one of the cancers that most affects women's health, and in addition to this, there's a component of being vaccine preventable. We can. This is one of the main causes of death from malignant tumors by cancer, and so this. The support that we received from scientific evidence was very important because our researcher, especially in the pediatric area, included this vaccine in the immunization schedule. I do remember that folks from the health ministry, including the minister at the time and a very active group of researchers, all came together in a room and they presented us with all of the evidence they had at that time. And after that, when the session ended, the minister said, let's go forward with this vaccine. That posed a number of challenges because getting parents to accept the use of this vaccine was no easy thing. We had to really work hard to get parents to vaccinate their 10-year-old girls. The idea that a vaccine to prevent a sexually transmitted virus would be administered to their 10-year-old little girl was something some parents had a hard time with, so we had to work on that. This also entailed a cost, and we had to make a hefty financial investment. So that's what the first process of introducing this vaccine entailed.
Compartir experiencias.
Muchas gracias, doctora Reina.
Thank you very much, Dr. Reina, for focusing on the scientific evidence and the importance of planning how you're going to introduce and roll out this vaccine. Dr. Bonilla, I know that in El Salvador, this vaccine was introduced, and during the pandemic, I'm sure that posed some challenges. Could you tell us a little bit about what your experience was? Of course, I'd be happy to. Yes, as we were saying before this session, El Salvador faced the challenge during the pandemic of doing this. That is to quickly eliminate cervical cancer. We took that goal on during the pandemic, and that is why we adopted the 90-70-90 strategy outlined by Dr. Jarvis. And so the biggest challenge we faced was educational, in which we had to show the population, as we just heard from the doctor here, how hard it is to explain to a parent and a girl how a vaccine was going to be administered to avoid a sexually transmittable communicable disease. But ultimately we did achieve high levels of acceptance by the whole of society, parents, teachers, children. So from 9 to 14 years of age, the vaccine was administered to girls, and then a single dose vaccine for women up through 21 years of age. We're still working on this. Again, this is met with much acceptance by all sectors of society. And before that, in El Salvador, this was not an accessible vaccine. It's only something that was made available in the private sector. It was hard to come by. Now, we have it everywhere. It's universally available. Everyone can be vaccinated, and it's free of charge. Schools, elementary schools are taking part in this effort. And my daughter has been vaccinated. So this is a tangible benefit that society has felt directly. And the strategic partners such as PAHO and the World Bank, who have supported us for the strategic, for adopting strategies that would enable us to benefit society in a bigger way than otherwise we would have been able to. So it's great to hear about the broad coverage that you have achieved and the acceptance by society. Now, Paraguay has been doing this, implementing this vaccine for more than 10 years. Can you tell us a little bit about your experience? Good afternoon, everyone. In Paraguay, we started in 2012 administering the VPH vaccine. There are women from 20 to 21 years of age who now, at that age, who, given that we started 10 years ago, have been vaccinated. Back then, now we have the single dose application, and now we are starting to administer this to boys born in 2014. From 9 to 18 years of age is the age group that is vaccinated. We did face some difficulties at the beginning of rolling out this vaccine, but we took this opportunity to vaccinate within schools children from 9 to 18 years of age. Of course, they're at school, and so we avail ourselves of that fact to vaccinate children, reach the largest number of children possible. Under the presidency of Santiago Peña, we established a very important strategy for vaccination in schools. That is Zero Hunger, rather, is the name of the program in schools. And so there are 7 very important programs that are part of that. One of the ones that health has a hand in is vaccination. So we're going to broaden our vaccination schedule. Now we offer a meal in school, a full plate of food by way of avoiding school dropout rates, and also that helps us as the kids are staying in school. It helps us with our vaccination program in schools. Now, as a part of a centralization effort, in 78 in Almada, the idea was health for all in 2000 with full participation of the communities. But during that whole time, we overlooked one of the very most important aspects, which is indeed community involvement in public health. We work on community engagement, outreach through municipal governments, where there's a local health council. This is a part of a decentralization program for health. And so from the time that these local councils, health councils were created, there was a transfer of funds, equity funds as they're called, in which money was transferred to these health districts, in which we saw health indicators that needed to be improved upon. So that's why we have this term equity funds. These are funds based on health results. And so what we did was to work with the mayors and with the local councils, given how important it is to improve health indicators, one of which is vaccination coverage. So whoever enhanced their coverage would receive more funds. These health results-based funds would be greater to the extent that they met their goals. So what we see is a substantive improvement of achieving these goals, which one of which is to achieve full coverage of vaccination of our vaccination schedule. Now, working with PAHO and UNICEF, we are training human resources, and part of that effort is outreach, getting families on board to get them to accept this. Now, something we learned during the pandemic is the importance of digitizing our health information, which we've done, enabling us greater traceability, and in real time we can see what our vaccination coverage is. That was quite an innovative strategy. I can commend you using these health results-based transfers to municipalities as a tool. Now, Paraguay is one of the few countries, well, not so few, but one of the countries that has adopted the single dose for HPV. What were the key factors that played into that decision to opt for the single dose? In Paraguay, we have the COTENAI, which is the National Committee for Immunization, and in that committee, we don't just have the public health higher-ups, but also medical experts, pediatricians, and so forth. So in this committee, decisions are made based on scientific evidence for deciding about what vaccines would be added to the vaccination schedule. And so COTENAI saw the need to opt for the single-dose approach. Now, what struck us was what we learned about applying the application to a to boys. We thought that was going to be hard to do, but actually it turned out to be a great opportunity, and it met with great acceptance by parents that their boys also be given this vaccine, not just their girls. I'd like to talk a little bit about coverage, because we know that historically countries in Latin America and the Caribbean have high levels of coverage in their immunization programs. But with this vaccine against HPV, it's been a bit of a challenge to achieve the 90% coverage goal. So we'd like to hear what strategies you're using. We've heard from Paraguay. But what about Panama? What were the strategies you've adopted? Our strategy to elevate vaccination rates was, again, to go to do so in schools, to go door to door, to people's homes, working with the private sector as well, to make sure that children seen by pediatricians receive their vaccination regardless of whether, and that they not be charged for it. Now, certainly the private sector does charge for the cost of the vaccine itself, but not the biologics. So we're still using the 2-dose vaccination. Now, we also have a vaccination committee in our country, and despite the fact that we have 96% of coverage of the first dose in girls, well, 99% in girls, 93% for boys. So we have surpassed the 90% goal of coverage for the first dose. But one of the reasons we have not yet switched to a single dose is because when we started with we changed the tetravalent, and starting with the 15-year-olds, in 2015 rather, with a strategy to cover from 10 to 15 years of age, girls. Actually, to bring the vaccination level of boys up to that of girls, as that had fallen behind. But the tetravalent approach was something we did to include other benefits that the tetravalent vaccine brings, for example, genital warts. And so the scientific evidence thus far shows, and we've been talking about this, we want to ensure the elimination of VPH infection now with the single dose, but we have not yet seen substantive sound evidence that would show that if we went from 2 doses to 1, that we will continue to offer the same degree of protection on that other factor that we want to include in the overall process of protection offered by this vaccine. So this is an element that indeed is important. Now, even though we haven't changed to a single dose, we have broadened the vaccination schedule, and we think that the at-risk group, men that have sex with men up until 40 years of age, women who have VPH positive, seropositive for HPV, and also from 10 to 15 years of age and children. So in this program, we are trying to, again, initiate the vaccination of boys, bring them up to the same level as girls. So we, again, have not moved to the single dose for the aforementioned reasons, but in the committee we're talking about this. We're still waiting to see sound scientific evidence that would warrant that change, including this other component that's so important for us to have included, because it is part of the reluctance to go from 2 to 1 dose, understanding that VPH can indeed be covered by a single dose. Now, there is scientific evidence that 1 dose can avoid infection by VPH HPV, and we'd be happy to share that with you as a part of the technical cooperation that we offer under the immunization program. That's precisely the type of evidence sharing that we do to assist you in decision making. Now, what I'm talking about is what we have not yet found is that genital warts will also be reduced with the single dose. With all the information we've seen, we have yet to see anything that tells us that the single dose HPV vaccine will also protect against the genital wart. El Salvador. What we've done is very similar to what we've seen in other Latin American countries for the implementation of this vaccine to eliminate cervical cancer. We're actually newcomers compared to my colleagues here. It's quite admirable to see the hard work that you've done at all the different levels. El Salvador has also implemented digital strategies. We have a 100% digitized vaccination schedule, enabling us to trace more broadly and to know exactly who's been covered, who hasn't been. Among our strategies, we also have the community walls-in strategy, door by door, not just for HPV, but we have overhauled our whole national vaccination schedule. That thanks to the technical cooperation that we've received from PAHO. Now, up through 2023, we achieved 80% coverage in girls and 73% in boys. As a country that is just starting this long process toward the elimination of cervical cancer, we're quite proud because we daily reach more and more people, making vaccines available free of charge, this vaccine free of charge. And so we're winning this battle step by step, brick by brick, as our president is wont to say. We are building a new health system in our country. We did not have that before. I like to stress that point because it's true. And nowadays we can be grateful that we can now offer this benefit directly to our population. Thank you. We know that with this, that the vaccine is not sufficient to eliminate cervical cancer. Screening for women between 30 and 49 years of age has to be done for the HPV test, and also women that have precancerous lesions or cancer also have to be given treatment. And so now let's ask about that. El Salvador, we'll start with you again. I know that El Salvador is one of the 4 countries in the region that has implemented the HPV testing nationwide. If you could tell us a little bit about that experience and what made you make that decision? As I said before, El Salvador has stepped up the pace of the testing for HPV, for screening that we're currently carrying out. We have broad coverage and availability of this test. We did not have that before. 731 different first-level centers were available at that time, 100% of which have this screening available. That enables us to achieve 100% coverage, and we are forging ahead to detect early any lesions. And as I said before, and I think this is part of what we'll be talking about later, but I'll go ahead and say it. It's beautiful to be there because from the ground floor, with that first exchange of information, of ideas, of notes, let's start with this idea, let's start with this strategy. After the screening, and then with the thermal ablation, that has given us such good results, and we have prevented so many deaths that way. And in Paraguay, Paraguay has been one of the 10 countries that has taken part in a study by the International Agency of Cancer assessing the use of HPV screening. So, doctor, how did that experience help you? I think the STAMPA study was a very important study for Paraguay. From 2014 to 2018, more than 10,000 women took the test, and with that, we saw that it is something that should become a regular part of what we do at the health ministry for women to be able to have this test, to be screened. After breast cancer, cervical cancer in Paraguay is the main cause of death in women. And the other very important fact is that of the 100% of diagnoses of of 90% diagnosis of cancer, 80% are in stage 2 or 3. So at that stage, death rate is higher. So what we're trying to do with this screening, with the HPV test, is for us to catch these cases earlier, to save lives, as my colleague from El Salvador said. So we have a program to ensure that all women can be screened early on, because in Paraguayan women play a very important role in the family. When a woman dies in the family, the whole family falls apart. So as a government in Paraguay, we're doing everything we can to meet the goal of the eradication of uterine cancer in Paraguay. Dr. Roa, now the HPV test has not yet been introduced, but you have broad coverage of the cytology test. Can you tell us a little bit about that experience? Well, we continue to use molecular tests and cytology for HPV. That doesn't mean that we're not thinking about introducing the HPV test, but in this process we're engaged in a discussion to see how and when are we going to introduce the HPV test. Now, it's very important that we raise awareness among women about them looking into what their situation is vis-a-vis cancer. People understand cancer to be a family problem, one that leads to death and additional costs, and that limits the development of a family. That's why we think that in order to introduce the HPV test within our strategic fund, much has been achieved in that direction, because when Panama was looking into the cost of rolling out this test, each one costs $60. So it's not financially feasible for the health ministry to use such a costly, such an expensive test at a large scale across the population. Now, we're researching to see what the impact of the HPV vaccine will be on cervical cancer. We have a group of researchers in our country who are engaged in that effort. The first phase, well, the second phase, is going to be looking into the genotypes of HPV that are in circulation in our country. So I think that all of these are elements that taken together need to be taken together, because we certainly are concerned about the burden of disease and mortality rate from HPV that lead to cervical cancer. So we need to have more epidemiological information on how much of cervical cancer can actually be caused by HPV, attributable to HPV, and it would be very worthwhile if from this organization that can be looked into to speed up the introduction in countries HPV tests for diagnostics purposes. Now, as far as the rapid test, the quick test, for those areas that are hard to access, far-flung remote areas, that's something where we are looking into using the rapid test. But there is a whole comprehensive package we have to look out, for which we need more scientific evidence from our own country that would enable us to justify financially at the ministry incurring this cost. It's going to be a greater cost. And we have to make sure they understand that this expenditure is in prevention, because you spare yourself all of the cost that's already going into treatment by making these investments in prevention. So that is our task before we can introduce this test. And so the minister is fully aware of the importance of this as a means of eliminating cervical cancer. And this is an opportunity for us to move forward and to apply the same strategy that we've been using to step up pap smear tests and cytology, which are concentrated mostly in primary care as essential to detecting early on any type of pathology, especially uterine cancer.
We have broad coverage in terms of gynecological obstetric care, and that will be the path that we have to follow if we're going to introduce, or when we introduce, the HPV test. Thank you very much, Dr. Roa. And of course, we stand ready to provide you with the scientific evidence as you introduce VPV testing. But you have also gotten very good coverage. So the strategy of using primary health care proved to be very effective. Okay, with that, we can go to treatment. We know that screening is not enough. We have to follow up on women that require treatment. The treatment has to be timely, it has to be thorough. And I know that in El Salvador, you are implementing a new strategy using thermal ablation devices. So tell us a bit about the experience in El Salvador. Yes, basically, I was there when the 75 first hypothermal coagulation devices were delivered. They were delivered personally by the PAHO officer in the country. So since then, we have been able to implement this at the different levels of care. The first level of care, the 700 and some health units that we have, we do screening, and then we move to hospitals where we can provide this treatment to patients in an effective way. As was said by my colleague here from Paraguay, unfortunately, sometimes the disease is not detected until it is rather advanced. But with screening, we have been able to increase the number of lesions that we detect early, and that has avoided a lot of deaths. Also, we have been training our our health staff, and they are very pleased because now they have another tool, an effective tool, so as to provide direct treatment to the people suffering from cervical cancer. And they can do so right from the start because everyone has had a relative, a case, someone that died from cervical cancer. So they are very happy to be able to provide support right from early stages for persons suffering from this disease. This is a disease that is currently preventable. And so we in El Salvador are very proud to be able to give this type of better care to our whole population. Thank you. And how about Paraguay? I would like to say that we did by 200,000 doses of HPV tests. So not only did we buy those tests, but we were able to bargain with the companies that we buy from. And each dose cost us only $20. So, and just like Panama and El Salvador, in Paraguay, we are implementing the primary health care strategy. And that's a strategy that in Paraguay has been in place now for some 15 years. And we always say that if we talk about the primary care strategy through the family health care units, the most important work, the fundamental work done by the family units is to keep people from getting sick. So that is their mission. That is their most important function for the family health units. There has to be prenatal control for women of childbearing age. The children have to be cared for. So we work with the family units, but it's important that those family units be the port of entry to the healthcare system, and that this works in coordination with the second, third, and fourth levels of care. So that is an important challenge for all countries, and we have to make certain that our network can function and that we can work in coordination. We in Paraguay have training facilities for different specialties in medicine. And one way of encouraging specialists to go inland and work there, we have a compulsory rural service requirement. And there they not only go to a hospital, the gynecologist serves in a hospital. It may be a surgeon, it's a gynecologist, it's an anesthesiologist, but they provide comprehensive care in these rural centers. And in that way, that service has resolution capacity. But in Paraguay, we also have centers for women. And in these centers, women come to them to do a colposcopy, or perhaps it's a referral center also. If in the family care center they find that a PAP has a precancerous lesion, they are referred directly to the centers for women. And in these centers, those women who had a PAP smear but didn't pick up the results, we have a system where we call these women to remind them that they have to pick up the results, and we always evaluate the result when we see that there's a precancerous lesion found on the PAP. So there, the diagnosis is established, and then the person can be referred to a higher level hospital, depending on what was found on the study. Now, another mechanism, and today we're talking about prevention of cervical cancer, we're talking about eliminating it, but what we're seeing now is that we diagnose a lot of cancers in advanced stages. So as the government of Paraguay, we are trying to make certain that the women, that the families, where there is a patient with cancer, we want them to be able to deal with this problem as close to their community as possible, to avoid uprooting these people. So we're trying to decentralize treatment, especially with hospital facilities where chemotherapy can be delivered. And another important datum, you know that Paraguay was one of the countries that recovered money from COVAX, and we received $3.5 million back. And the decision made by the president was to buy 2 linear accelerators. So today, within the public system, the only place where we can do radiotherapy treatment is in the capital city. But now that he has bought these 2 linear accelerators, we're going to go to the 2 departments that have the highest affected population so that we can accelerate treatment, and that way people can receive treatment as close to their own community as possible. And that avoids uprooting these people, and also it reduces out-of-pocket expense, because these are families that may spend 7 or 10 days at the site to get treatment. Thank you. And thank you for reinforcing the health system so as to treat invasive cancer. And also for strengthening the connection between primary health care and other levels. Now, to promote the strategic and the Rotary funds, because we have the HPV tests that are at a lower cost than what a country can get by negotiating directly with the manufacturer, we would suggest that you use the fund that we have. It is quite cost effective. And I know that in Panama, you have a lot of experience with strengthening treatment for cancer. Yes, in the first level outpatient network, we have colposcopy. We do diagnostic and therapeutic colposcopy. And once the diagnosis is established, we can opt for colposcopy depending on how advanced the tumor is. And otherwise, the more advanced surgical processes that are more invasive to deal with the problem. Now, we're working with decentralized chemotherapy too, although a lot of this is consecrated in the National Oncology Institute, and that is in 3 health regions of the country. Radiotherapy, radiation therapy is available, and in addition to external radiation therapy, we are using intracavitary irradiation. Once these processes have been accomplished, we're working on increasing the capacity of linear accelerators so as to provide the radiotherapy needed throughout the country, because that's not only used for cervical cancer. It is important to say that for adolescents, we're working with FUSPA in the adolescent centers so as to also give information on sexual and reproductive health. And that includes talking about the prevention of HPV as a way of preventing cervical cancer. To conclude our panel, I wanted to give you a bit of time to convey your clear message to all member states. And let me begin with you, Doctor. I would like to take this opportunity to encourage all member countries to get on this train to eliminate cervical cancer. I think that this is something we can do. And if we all work in the same direction, we can do this. And that will create a big impact for all families of member countries. They will know that we can prevent cervical cancer, we can save lives, thanks to this initiative. So thank you. Thank you, Doctor. Dr. Bonilla. Thank you. I think that the key here is to look at cost effectiveness, and we are proving that. And this also encourages us to call on others to join us in implementing these strategies, because this delivers a true product that actually does improve the quality of life for a whole country. And that is hard to do, but we are at a juncture where this can be done, and the sooner we do it, the better. Thank you. Yes, now on the part of Panama, we would call on you to join us in promoting this cause of eliminating cervical cancer. This is one of the pathologies that affect women's health, and it's always easier to accomplish this task if we all work together. Thank you. And thank you for sharing your experiences, and thank you for encouraging countries to make the necessary changes so as to eliminate cervical cancer. But we still have a few minutes, and so I will offer the floor to the countries for questions or comments. I know that other countries have also been implementing programs to increase vaccination, testing, strengthening treatments, also from our partners that are part of this session. So the floor is open. Good afternoon. It's a pleasure, and thank you very much for sharing these experiences with us. They definitely do strengthen the region. I am Dr. Torres from Mexico. There is an element that is important, and I think that that is visibility. Visibility of groups that traditionally have been at high risk. We're talking about persons living with HIV. In Mexico, we are vaccinating the people, men and women that live with HIV, and the cis partners are also included because this is a population that is at high vulnerability levels, and also there is the risk of these conditions progressing. So it is important that we have this person-centered, community-centered effort with actions in health that are measurable. Now, and looking at the centered care, what we have come to realize is that in addition to the vaccination elements, often we forget other actions. In other words, being able to provide thorough care for the other comorbidities, including, for example, doing PAPs, doing cytologies. We have tests to detect HPV. But when we look at the histories, and if we look at the platforms, and here talking about the importance of having an information system that is integrated, what we often find is that unfortunately, we aren't even reaching 1/2 of the people that have all of the elements covered. In other words, not only is it vaccination, have they done their cytologies? Have they been involved in a colposcopic follow-up, et cetera, et cetera? So it's not, or actually in the long run, although we have a policy, we have guidelines, we have all of these inputs, but in the final instance, it is very important to empower individuals and communities so we can implement a policy that will be people-centered. Thank you. And yes, community participation is tremendously important. Are there other comments, please?
For this session, my name is Lisa Stevens. I'm from the International Atomic Energy Agency, and I just wanted to thank the panelists for mentioning the importance of radiotherapy in the elimination strategy and that 90% access to treatment pillar for elimination. We work very closely with our colleagues at PAHO and in the other regional offices to contribute to not only ensuring that radiotherapy is integrated into a comprehensive cancer control strategy, but also diagnostic imaging and nuclear medicine for other types of cancers. So I just wanted to reflect on that. And again, thank you for the session and for sharing all of your insights.
Thank you, Lisa, and thank you for all the wonderful support that the impact missions have brought to some of the countries here and in our region to help strengthen radiotherapy services. Thank you. Are there other reflections, comments, questions? Yes. Oh, Susana, adelante.
Buenas tardes a todos.
Good afternoon, everyone. My name is Susana, and I'm from the Latin American Perinatology Center, where we work with women's health, reproductive health. So this is something dear to our hearts. In October, we're going to organize a workshop that has to do with today's topic and the community topic, and it's self-care, because now there's this test that represents an opportunity to make great progress in terms of cervical cancer. So you can do a self-sampling, and that is very important for the women of the region for several reasons. So what happened to the countries who fortunately have a lot of tests is that they can experiment on this. In many countries, we can't reach all communities, but self-testing is something that women can do. So it's self-care. Our workshop is about self-care. It's not only about self-sampling. So we will be talking about maternal health, etc. But the priority countries have been invited, but we would love it if other countries could join us. So thank you, Silvana. And I wanted to congratulate everyone on the progress that has been made in this area. Thank you. Thank you, Susana, and thank you for reinforcing the idea of self-sampling to do the HPV test. This can increase coverage, involve more women, and reach remote populations.
Reflections? I know it's a long day, a lot of meetings. So, okay, well then let's just end this panel, and thank you to all of our panelists for sharing your experiences, and I'll turn back to Dr. Hennis for some concluding remarks. Dr. Hennis for concluding remarks, thank you.
Yes, well, thank you so much to member states who have participated. Thanks so much to the panel for sharing those very deeply insightful experiences on cervical cancer elimination progress in the countries in Panama, in El Salvador, and Paraguay. And we've learned a lot. There's been a lot of food for thought in terms of issues like screening, the challenges of the various tests, the way that there's been a transition to the DNA HPV test, so it is entirely possible. The fact that in terms of vaccination, and some of the challenges that were shared, for example, the low acceptance, the low uptake, and how these countries successfully overcame these barriers to facilitate, to use different methodologies, to use the school environment, and also to use communication techniques to bring up the uptake of vaccination. And of course, the treatments. And of course, I'm just going to make another plug for the fact that in the PAHO Regional Revolving Funds, there's access to screening tests, DNA tests. There's also access to vaccines. There's also access to thermoablation. There's also access to colposcopy. The tragedy right now in this moment is that Latin America and the Caribbean really has the second highest mortality from cervical cancer in the world, second only to Africa. And we can do so much better. We have a very long, successful history of success in elimination of vaccine-preventable diseases. It is time for us all to step up, to build on our previous experiences, lessons learned, and to forge a way ahead so that the region of the Americas becomes the first region in the world to eliminate cervical cancer. That is our challenge. So we're here to accompany you. All the best, and thank you for your participation.